Hi, everybody. We're going to get started in about 5 minutes here, but in the meantime, I wanted to let you know that they did bring coffee and tea out. So if you want to grab a coffee or tea or water quickly, now is your time before we get started. Hello again, everyone. We are going to get started and right on time, so that's great. Thank you to everyone for joining us today. My name is Ashley Croning, and I am the Director of Community Engagement for the Arthritis Society BC and Yukon Division. And joining me as well today, we have Linnea Westland, who is our Community Engagement Coordinator for the Interior region. So if you're ever calling the Arthritis Society here in the Interior, you are likely going to be speaking to Linnea, who's based out of our Kelowna office. We're very happy to be here in Kamloops today at this Arthritis Connect Symposium on arthritis and pain management. I'd like to welcome all of you who are joining us in person, as well as those of you who are joining us online. And whether or not you are here in the room or online, everybody will have an opportunity to ask a question. We're going to be doing questions at the end of all of the presentations today. We will, in the middle of the session, be taking about a 10-minute break, so everybody can use that opportunity to get up and stretch. But being it's an arthritis event, we are very familiar that people have joint pain, and so if at any point throughout the presentation you do need to get up and move around, please feel free to do so. And for those of you in the room, I just wanted to take care of a couple housekeeping things. We do have water and coffee and tea, as I mentioned earlier, at the back of the room. And then the washrooms are just outside the doors here by where you came in to the right. So before we get started with today's presentation, I wanted to tell you a little bit about the Arthritis Society. We are a national health charity fueled by donors and volunteers with a vision to live well, where people can be free from the devastating effects that arthritis has on lives. The Arthritis Society began 70 years ago with one very clear goal: to alleviate the suffering of people affected by arthritis. We were founded in 1948 by Dr. Wallace Graham and his medical peers from across the country, but it was Mary Pack, a fiercely driven community advocate from right here in British Columbia, who worked tirelessly to put people's needs with arthritis truly in the spotlight. And Mary's vision continues to be what drives us today. The Society is supported by more than 13,000 extremely dedicated volunteers, a few of which are here today. And I'd like to say a heartfelt thanks to all of those volunteers who help us do the things that we do as an organization. So as I mentioned earlier, this is the Arthritis Society's vision: to live in a world where people are free from the devastating effects that arthritis has on lives. And our mission is to invest in cutting-edge research, proactive advocacy, and innovative solutions to deliver the best possible health outcomes for people affected by arthritis. I wanted to tell you a little bit about our research. So we are the largest charitable funder of arthritis research in Canada, and we've invested over $200 million in research projects since our founding. But unfortunately, in 2017, we did have to turn away a number of research projects that were full of possibility due to a lack of funding. And here is a bit of an agenda for today. So we will start with Dr. Nancy Hudson, followed by Jackie, who will be joining us via video to talk a little bit about her journey with arthritis, and Samantha, who will also tell us about her journey with arthritis. We will then have a bit of a break, and Dr. Chris Spooner will speak following the break. So on to the main event. So we are very fortunate to have Dr. Nancy Hudson here with us today. Dr. Hudson is originally from Quebec and moved to Kamloops in 2003, where she became a community rheumatologist. So please join me in welcoming Dr. Hudson.
Okay, yep. Hello. Thank you for being here. I recognize many faces, and I'm happy to see those that I recognize. And hello to all those that I don't recognize. I think we share a common situation here, and arthritis is a big problem in our community and in our lives. And I'm hoping to bring a little bit of attention. What I want to talk today is, what is arthritis? There are different types of arthritis, and furthermore, what's coming now with the management of some of these different arthritis. So arthritis is a big curtain, and it involves two main branches. Arthritis is a problem with the joint. So a joint is where two bones come together. There can be a mechanical problem in the joint, so that's one type of arthritis. And there can be an inflammatory problem with the joint, and that's what these immune or autoimmune types of arthritis are all about. And I'm going to try and describe a little bit what the difference is, because obviously they're managed differently. So this is a picture of what a normal joint should be like. And I think it's important to understand the anatomy. If you understand the anatomy, then you can understand what's going on. So two bones come together, and between the bones, we have the cartilage. Cartilage is that pillow so that you're not bone on bone, and when the joint moves, there's a smooth movement between the bones. Every joint is wrapped up by a synovial capsule, but around the joint, we also have very important structures, such as the ligaments. Ligaments hold the bones together. We have the muscles. The muscles are what move the bones, and those muscles become tendons, and that's what attaches to the to the bone, and that's what allows that movement to happen. We also have bursa. These are these little pockets of fluid that are between bone and muscle that allow for normal movement, for easy movement between the joints. So that is what normal anatomy should be. What happens in osteoarthritis, the most important problem, is that the cartilage, which is the pillow between the joints, starts to wear out. And as it wears out, therefore the joint, and it doesn't wear out in a nice even way, it wears out a little bit here and it wears out a little bit there. So the joint now is not aligned like it should be, and therefore movement is inhibited. So that is what happens with osteoarthritis. It is a mechanical problem, same as in your car. If the pieces are not fit together properly, things are not moving properly together. What happens in inflammatory arthritis, it's different. In inflammatory arthritis, this is your immune system that causes this. So it's not a mechanical problem at first, it's the immune system. So our immune system is meant to recognize viruses and pollutants and bacteria to protect us. What seems to happen in these immune abnormalities is that your immune system starts to recognize something of your joint as being abnormal, certain proteins, and so you start mounting an immune response to it. So at first, what happens is that there's swelling, there's redness, there's heat in the joint, and because of that, the joint hurts, so there's pain related to it. If we let this pain and swelling continue, so untreated, with time, then this swelling starts to chew into the bone, into the cartilage, and into the other structures, and so it leads to damage, which is what osteoarthritis is. So rheumatoid arthritis or inflammatory arthritis often start as an immune response, but then can lead to secondary osteoarthritis. And so this is what this picture demonstrates, is at first the inflammation is around the structures of the joint, but with time it will lead to joint destruction, very similar to a picture of somebody with osteoarthritis. It's just that the way that it starts differently. I want to point out here that there's when we talk about the signs and symptoms of arthritis, we mean two different things. Signs are things that we can touch, that we can feel, that we can see, such as swollen joints, deformities, joints that don't move the way that they should be, nodules underneath the skin, rashes. These are the signs of arthritis. Symptoms are things that patients feel, but that we can't necessarily see, such as fatigue, which is often a major complaint of patients with disease, pain is a problem, gelling either after prolonged immobilization. So when you're going to be sitting here for a few minutes, when you come to get up, there's a lot of gelling in your joints. Or in the morning, for example, early morning stiffness after patients have been asleep for many hours, what happens is they come to get up and all of a sudden they're very stiff and sometimes for a prolonged period of time. So that is what's different between the signs and symptoms. And so when you go to your doctor and you're reporting on different things, these are part of the questions that will come up that help us determine what's going on, because some of the signs and symptoms of osteoarthritis will be different than the signs and symptoms of people with inflammatory arthritis. So when we talk about osteoarthritis, which I said is a mechanical problem with the joint, the main risk factors for osteoarthritis are, number one, genetics. If mom and dad had it, you're more likely to get it. And that's just the way it goes. That is your genes, that's the way you're made. The other risk factors are aging. This is wear and tear. This is life, this is a lot of work, this is falling out of a treehouse when you were 3 years old. It is the way that it is. With aging, our joints take a beating, and they do get to wear out because of that. And finally, the other risk factor is trauma. And that's where you'll hear, you know, that 20-year-old football player gets it in his knee because he's had his knee bashed so many times that the cartilage is wearing out faster than it should be. I want you to imagine a little bit osteoarthritis. The cartilage is a bit like the hem of a skirt. And with time, it's just kind of just coming off, just slowly. That's what's happening. So I usually tell my patients with osteoarthritis, if it took 50 years to get here, it's going to take another 50 years to get worse. So this is a progressive condition, but generally slowly progressive. And that is the nature of what's happening in osteoarthritis. I do want to point out, though, that there is a small subset of patients who have what we call erosive osteoarthritis. Maybe about 5, perhaps up to 10% of osteoarthritis patients have a much more rapidly progressive course than the usual kind of aging process that we see. And in this case, when we do identify these patients, we tend to treat them much more like inflammatory arthritis. We tend to be more aggressive with the management with these patients. So what is inflammatory arthritis? So as I mentioned, inflammatory arthritis is your immune system. So although the problem that you're feeling is in your joints, the problem is actually your immune system. So your immune system is recognizing something of you, and by doing that, it's causing an inflammatory response initially in your joints. But if you don't do anything about it, with time, it can also migrate to other organs. It can affect your eyes, your lungs, your heart, your kidneys, and so on and so forth. There are different types of inflammatory arthritis. The most common one that we talk about is rheumatoid arthritis, which affects about 1% of our population, and it's quite common. Other types are, for example, psoriatic arthritis. These are patients who have psoriasis, and this is a skin rash that patients will get commonly on the elbows, on the knees, sometimes in the scalp. About 1/3 of patients with psoriasis will develop an arthritis associated to their psoriasis. So this is also a common form of arthritis out there. Another common form is ankylosing spondylitis. This is when the immune system, you know, when we talk about rheumatoid arthritis, we're talking more peripheral joints, joints of the arms and the legs. But in ankylosing spondylitis, in this condition, it affects more the axial skeleton, more the spine, the chest wall. That's where these patients manifest their symptoms. Systemic lupus erythematosus is another common inflammatory disease. This one affecting patients certainly in the joints, rashes in the skin, but can affect the kidneys, can affect the heart, can affect the lungs, so usually much more extensive. At the bottom of this list, I want you to notice that there's a category called undifferentiated inflammatory arthritis. And when we say the word undifferentiated, it doesn't mean that we don't know what you have. We know what you have. You have an inflammatory arthritis. You just don't fall in a neat category. You don't have the antibody that says you have rheumatoid arthritis, or you don't have the antibody that says you have lupus, but you still have an inflammatory arthritis. And so about 1/3 of patients who present initially have an undifferentiated form of inflammatory arthritis. About half of these patients will eventually differentiate. They will develop a CCP positive antibody and will say, aha, you have rheumatoid. But there will be some patients who will never really distinguish their disease. It doesn't really matter because in the end, they're all treated pretty similarly. So we tend to treat these patients similar as we would treat a patient with rheumatoid arthritis. The other name for that you might have heard would be seronegative rheumatoid arthritis, but we've now classified it as undifferentiated. There's a whole bunch of other inflammatory arthritis too, such as crystal-induced arthritis. These would be patients who present with gout or pseudo-gout. That's when either uric acid or calcium precipitates in your joint and causes swelling. There can be people with metabolic diseases such as hemochromatosis that can present with arthritis, and granulomatous diseases such as sarcoidosis, which is a common condition that can manifest itself also as an arthritis. So I talked a little bit about the signs and symptoms of arthritis. What I want to point out here is that not all pain is arthritis. And that's really important for us to kind of spend a bit of time. When a patient comes into my office, most of the time they're complaining of pain. And so for the patient, pain is pain. My job is to determine where's that pain coming from, because obviously that's going to determine how I'm going to treat the patient. So yes, there can be a problem in the joint, and that's an arthritis. But there can also be a problem with the muscle. That would be a metabolic muscle disease, let's say. There can be a problem with the nerves, a neuropathy. There can be a problem with the tendon. That would be a tendonitis. There could be a problem with the bursa, which is bursitis. There could be a problem with the bone, either a lesion, a cancer, something growing. And then furthermore, there could be pain that originates, which is what we call more central pain. That's a little bit when we talk about fibromyalgia. And so fibromyalgia, we can cut the muscle and look at it under the microscope, it looks normal. We can cut the bone and look at it under the microscope and it looks normal. But what we do identify in these patients is that the pain is more at the level of the brain. This is where they're sensing the pain. So when patients are complaining about pain, it's really important to take the time to determine where's this pain coming from. Because as I said, the management will be different depending on where the pain is coming from. There are also important factors that contribute to pain, such as physical activity. If you overdo it, it's going to hurt. That's the way it goes. And especially, as we get older, we can still do what we used to do when we were younger. The physiologic change is we don't recover as well as we used to. So if you overdo it, it's going to hurt. So physical activity can have an impact. Joint damage, depending on how the joint is moving, that'll have an impact on how your joint feels. And when I say overdoing it, there's also deconditioning. If your muscles are not in good shape, that's also going to cause a lot of aches and pains around the joint when you're trying to move. Even activities that you think, I should be able to do this, but if you haven't moved for a while, your muscle is suffering. Your muscle needs to be toned to be able to give the output that you want it to give. And then certain psychosocial things can also affect the way that we feel pain. And probably one of the most important is sleep deprivation. When we don't sleep well, we don't feel well. That's the way it goes. It doesn't matter if you have arthritis or not. If you don't sleep well, you don't feel well. And because of that, it accentuates the pain. Other things such as stress and anxiety in our lives will also make us more tuned into our pain, whereas when we're more relaxed and it's summertime and it's warm, we're not so tuned into our pain. So there's different factors that affect the way that we feel pain as well. So making a diagnosis, as I said, is really important because that's what's going to determine how we do therapy for our patients. And probably one of the most important thing is taking a good history from our patient. I think that 90% of the time, I pretty much have made up my mind after I've spoken to my patient what's going on with them. And yes, the labs are going to help me, and yes, other things are going to help me, but the way that they describe their symptoms, if their symptoms are more peripheral versus if their symptoms are more axial, if their symptoms are more in the morning, if their symptoms are at night. So taking a really good history, and so that's the kind of thing that you want to communicate to your doctor when are your pains? What type of pains are you having? What makes the pain worse? What makes the pain better? These are some of the features that we're looking at for us to make a good diagnosis. I think a physical exam is also really important for us to be able to pick up certain things that often I pick up things that even my patients haven't noticed. So certainly joint involvement is something that's really important for us to be able to determine what's going on. The mobility of the spine. Many times people don't go through their full range of motion every day. They don't know that their spine doesn't move like this or doesn't move like that. So those are things that are important for us to determine. Looking for rashes. And so when I talk about psoriasis, many patients don't even notice that, oh, yeah, maybe I do have a little bit of psoriasis. Never really paid attention to it. Subcutaneous nodules are important. Nail changes, which will appear in psoriasis, are, again, things that we sometimes pick up. Eye involvement. So interestingly, there's a lot of similarities between inflammatory arthritis and eye diseases. And so that's often something that we ask about in our patients and will lead us to a diagnosis or another. The workup can be as simple as some lab tests. And I mean, many of these lab tests have been around for quite a while. Probably the one I'd like to point out is this joint stat, JS, that has now been on the market for a couple years. It's still not covered by MSP. It's an interesting blood test because the rheumatoid factor and the CCP are very good for rheumatoid arthritis, but they don't go up or down with disease activity. So what I mean is once you're positive, you're always positive, whether your disease is really, really active or whether your disease is in remission. And so it's not, so once we've done it, there's no use in following somebody's CCP or somebody's rheumatoid factor because it doesn't give us any kind of information about disease activity. What seems to be very interesting with this new blood test, the joint stat for rheumatoid arthritis, is that it does seem to correlate a bit like one of the markers of inflammation. When the inflammatory response is very high, the titer is high. When the inflammatory response goes down and disease goes in remission, it tends to go down. So I think that there's going to be a very good clinical utility in this blood test in the future. So that's something that's new in terms of making different diagnoses. I wanted to point out too, for x-rays, many times when when I see a patient and we do x-rays, and the x-rays come back as normal. And the patient goes, well, how can that be? I have so much pain, And that's good. I want to reassure you, it's good that it's normal because x-rays are a very crude measure. All they really tell us is about bone. They just tell us about the structure and how things are aligned, but they don't tell us anything about inflammatory response or how much inflammation there is in that joint. So the fact that the x-ray is normal at the outset means that we've got earlier disease. If already at the outset we're already seeing erosions or different types of damage on x-ray, then that usually tells us that this has been going on for quite a while and we need to get on the ball with managing this. So don't worry if the x-rays are normal. It doesn't mean there's no problem. It's actually a good sign. It means we're dealing with earlier disease. And then, of course, there's other modalities of imaging, ultrasound and MRI that have been used and are becoming much more current now. In the States, patients waiting to see their rheumatologist in the waiting room will get an MRI of their hand. So by the time they come in to see the rheumatologist, images are up there. It's coming. So it's just a cost issue more than anything, but it's pretty fantastic. So making a diagnosis is what I think the most important thing because obviously not all diseases are treated the same and I think that we have to make sure that we make the proper diagnosis. And I think that the other thing I want to point out too is that different conditions can coexist. You can have rheumatoid arthritis and osteoarthritis and fibromyalgia together. So it's not just one or the other. You can have several conditions going on. And that's important to identify because sometimes I will maybe initiate a treatment with one of my patients and then they come back and I say, well, how's it going? And they go, well, I still have pain. And I go, okay, but let's try to figure out where's the pain coming from because if the swelling went down, well, that's good. Maybe the rheumatoid is under control. You still have pain because it might be the fibromyalgia or it might be the osteoarthritis or you might have a tendinitis. So it's important to know that you can have different things. And so what I try to do is I really try to establish all of the different things that are going on and then you address each one of them independently and that's how you're going to get the best response overall for your patient. So I'm going to turn my attention now a little bit to treatment of inflammatory arthritis. There's a couple of things I want to point out. There's this whole treat to target. This is now the new words that are coming out in terms of trying to manage arthritis. What that means when we treat to target is that we aim for 100% remission. That is our goal. Do we always get our goal? No. And if we don't, That's when you tweak things. That's when you change things. That's when you adapt things. So in the past, when there was really no other treatments, you know, we tell our patients, well, this is it. This is how you're going to be. But now with a lot of new evolving therapies that are coming, we're able to keep aiming for better and better management of arthritis. So that's what that means. Early and aggressive management is also really important. And what I mean by that is, 50 years ago, when we had patients who had rheumatoid arthritis, and we had these medicines, but we didn't have good experience with them, and we knew that there was risk to the medicine, we used to tell the patient, this is not so bad. You know what, just hang on, it's not so bad. But then if you wait and you wait and you wait until the damage is done, then you've missed the boat 30 years ago. It's too late. We've missed the boat. So that's where now the pendulum has swung to, we want to treat early, we want to treat everybody, because that's when the best outcome will be for the long term of our patients. I think it's also important to stress the difference between what a therapeutic management versus a symptom management is. So therapeutic management means we are altering the course of the disease. So what I mean by that is, if you have a patient with rheumatoid arthritis and I give them a therapy, their rheumatoid arthritis will go in remission, and then they will not have the sequelae, the joint deformities, the lung and the heart and the eye complications. Whereas symptomatic management is mainly aiming to keep our patients to, it's mainly for pain or other symptoms. A lot of patients have dry eyes, dry mouth. Some patients have a lot of fatigue. These are the symptoms that we're addressing, but they don't necessarily change the course of the disease. And so, for example, here I'm exaggerating when I say this, but I could give morphine to a patient with rheumatoid arthritis. They have no pain, but the disease is still going on. So there's a difference between therapies and symptom management, but they go hand in hand. Because if I don't address the pain and the symptoms of my patient, they're not going to be able to function very well either. So the two of them are really very closely linked together to get the best outcome that we can for our patients. As many of you know, there's 4 big categories that we use to treat inflammatory arthritis. Non-steroidal anti-inflammatory medications such as Aleve, ibuprofen, they help. They take the edge off a little bit. They would never be strong enough to stop the disease. The next category is the steroids, such as prednisone, or for some patients we can put Depomedrol into the joint, or sometimes intramuscularly. They work great, but they got lots of side effects. And so it would never be how we would want to treat our patients in the long term. So they do have a role in the management, but I call them more my bridging therapy. So if I've got somebody who's really having an issue right now, on the short term, they'll help us until we can figure out a longer term therapy. Then there's the DMARDs. These are the disease-modifying anti-rheumatic drugs, and I'm sure many of you know methotrexate, sulfasalazine, hydroxychloroquine, leflunomide. They've been around for 50 years, and they work quite well, and that's been our traditional therapies, and we still use that first line for most of our patients. But what I want to concentrate a little bit more now, because that's what's more current, is these new biologic agents that have come out, which are very good and very helpful in the management of our arthritis patients. So biologic agents have been available for over 20 years now. One of the issues is that they're very expensive. And that's probably why we don't use them as first line. If it wasn't for a cost issue, probably would be the first way I would always address my patients' therapy. But because they're very expensive, we cannot use them as first line. They're expensive because of the way that they're produced, and I'm going to get into that a little bit after. They work, their mechanism of action is also very interesting. Whereas the traditional DMARDs, the methotrexates of this world, they basically were non-specific. They just blanket your whole immune response, hoping to capture in that part of your immune response that's overactive to try and prevent disease activity. With these biologic agents, they're much more targeted to a particular cytokine or cell in your body, and therefore the response is much more effective and selective. Their safety profile, now that we've had them for over 20, 25 years, we're understanding much better, and they are safe. And they're just complicated to get our hands on, and that's why I'll talk a little bit about that. So this is a picture of, just to imagine, just to give you kind of a visual of the difference between a biologic agent. And so on the left, you have what a molecule of aspirin would look like. So aspirin is a synthetic, organic molecule, small size. Compared to what we're talking here, biologic agents are monoclonal antibodies. They're very complex proteins. Other types of biologics, if you want to kind of have an idea, biologics would be things like Botox, so botulism toxin, which we inject for muscle spasm, or blood products are biologics. They are things that are natural to our body. And so these biologics that we're talking about today for the management of arthritis are antibodies. We are giving antibodies to our patients. They're quite complex, and they take a lot of steps in labs to be produced, and that's what makes them very expensive. More recently, you might have heard of the biosimilars. So the biosimilars, they're not generics. Generics means that it is exactly the same molecule as that aspirin molecule. In biosimilars, it means they're pretty similar, but they're not quite. So for example, if you just look at this diagram where the gestalt is, it's pretty much there, all of the proteins, but there's just 2 or 3 little differences between them that are not quite the same. And so the benefit of the biosimilars, so according to the FDA, they should work exactly like the other products work. And studies have shown that they work quite well, but they're much less expensive. And I think that that's going to improve our access to our patients at getting them on board biologic therapy sooner than otherwise. So as I said, they have a mechanism of action that is much more targeted than the traditional DMARDs. And they target different things. So the original biologics that we had were targeting this molecule called TNF, tumor necrosis factor. But now as science is evolving, and I can tell you this is where the research is going, we are determining all sorts of different pathways. And so now the interleukins, 1, 2, 6, 17, 23, are also being targeted as different targets to modulate the immune response. We have different ones to target the T cells and the B cells and intracellular mechanisms. So science right now, this is where it's going. It's to try and understand a little bit the immune response. And by understanding the immune response, we know where to target it. So the immune response is a really complicated, and it's hard to explain. It's harder to explain than everybody can understand a gallstone in the gallbladder. You can kind of visualize it. Or you can understand a blood clot in the vein because you can kind of see it. It's really hard to understand the immune response, and it's hard to understand what goes wrong with the immune response. But your immune response is really complex, and so your immune response is meant to protect you from threat. So just imagine you're in your house, and in the backyard, there's a bear. This is a threat. And so all of a sudden, you're going to respond to the threat. So the threat could be you turn on all your lights because you bang some pots. That's your initial threat response. But then you might text your neighbor and tell your neighbor, hey, there's a bear in my backyard. So that text is like these cytokines, these TNFs, and these interleukins. They're now sending messages to other cells to say, hey, we have a threat. Therefore, now these cells are responding by sending more messages to other cells. Sometimes you might even send a message, but by mail. So that message is going to take a long time to get to your neighbor. And that's where some immune responses are what we call delayed immune responses. So our immune response is very complex. And therefore, the other thing that's really important to understand is that we all... Sorry. I tend to speak with my hands because I'm from Quebec. We all respond differently. So some people might send text, some people might send, envelopes, some people might do different things. And that's the problem with the immune response when it comes down to the individual patient, is that we all respond differently. And therefore, what one therapy might work for one person, it might not work for the other person, and vice versa, because maybe in one case, Their TNF response is higher, but in this case, their interleukin response is higher. So I think with time, and this is again where science is putting us, pointing us towards, there will be blood tests where we will be able to personalize our therapy to patients, where we're going to say, whoa, this person's response is much more of a TNF response. Let's use the anti-TNF. Whoa, this person has so much interleukin in their joints. Let's use the anti-interleukin. So with time, we're going to be able to use biologic markers in the individual patient to be able to tailor our therapy much more appropriately without necessarily kind of a bit of a hit and miss approach that we do have at this point. Okay, now probably, yeah, there you go. This is just a quick summary of what is on the market right now from, which is approved by BC Pharmacare, but I can tell you that there are hundreds of different molecules coming. The common anti-TNFs, we've had like etanercept and infliximab for over 20 years. Some of the newer ones, like the JAK inhibitors, there's a new one now, baricitinib, that's just been approved as of last week. So there's lots of different options. And I think that there's not one perfect approach for every patient, but with time, maybe we'll be a little bit more selective about how we can treat our patients. I also want to point out that biologics are being used now throughout all other fields of medicine. It's not just in rheumatology. We're using it in osteoporosis, such as Prolia. They're using it in cardiology for preventing platelets after stenting so that there's no clotting. It's being used in oncology, Herceptin for breast cancer, or allergies. This is Xolair. And there's even newer ones, tanezumab, which is being now developed. It's a nerve growth factor it's a monoclonal antibody to prevent nerve growth factors, and it's being used in pain, especially the management of pain and osteoarthritis. So lots of research going through biologic therapies. I want to say that they are very efficacious. They work very well. On average, I would say that a patient with an inflammatory arthritis, about 40% of patients will respond adequately to a traditional DMARD, which means about 60% of patients don't have an adequate response. So they have opened up a huge amount of therapies available for our patients who are not responding to the traditional DMARDs. They are effective in different indications, everything from rheumatoid to lupus to vasculitis. We're using them now. They tend to work better when they're given together with one of the traditional DMARDs, such as methotrexate. Probably for a couple of reasons, but one of the most important reasons is that these are antibodies, these biologic therapies. What can happen with time is that your immune response can develop an immune response to that antibody because it's not yours. So we call these anti-idiotypic antibodies. What seems to happen is if we give it with a little bit of methotrexate, not the doses that we would use to treat the disease, but lower doses or sulfasalazine, we don't develop these antibodies as much. And therefore, the benefit will be longer lasting in these patients. And then we certainly switch from one to the other when we feel that there's inadequate response. From a practical point of view, probably the most important thing I talk to my patients is what is the risk of biologic therapies? The most important risk is the risk of infection. They certainly increase the risk of infection twofold, everything from an upper respiratory tract infection, urinary tract infection, cellulitis, pneumonia, that kind of thing. So what's important to remember is that your white blood cell count, that is your first line of immune defense in your blood. Your white blood cell count is normal no matter what biologic therapy you have. So your first line of defense is normal, even when you're on a biologic agent. But if you get an infection, you don't respond to the infection as well because now you're blocking your immune response. So therefore, the most important thing to remember is if there is an infection, hold the biologic. Don't give yourself your dose. Don't, delay it because then you want your normal immune response to fight the infection. And once you've had the, resolved, you've had your antibiotics, you've waited a few days, things are okay, then you can resume it. So that would be one of the most important messages is if you do have an infection, hold your dose. The other thing that we have to think about too is the risk of certain infections that are preventable by vaccinations, and I certainly recommend vaccinations throughout my practice. Flu vaccines on a yearly basis, I recommend them. But even all vaccinations, and you know, we're really good with our kids, they're on these schedules and 2 months and 4 months and 6 months, but as adults, we do also have vaccination schedules that we should be making sure that we're compliant with. And so that means getting your pneumonia shot every 5 to 7 years. That means repeating your booster for diphtheria or tetanus. That means looking into the shingles vaccine if you're over the age of 50. So making sure that your vaccinations are up to date to prevent infections are really important as well. Remember, though, that with biologic agents, when I talk about vaccinations, the one thing that we say is that you should not be receiving any live vaccines. So what I mean by that is that there's different types of vaccines. There are the protein-based vaccines. This is like the flu shot, where they give you a protein, and then you mount an immune response. So if the flu comes in, you're going to fight it. Whereas there's the live vaccines, such as the chickenpox vaccine, where they're actually giving you the chickenpox. It's an attenuated version, so it's not as serious, but that's how you mount your immune response. What we worry about our patients with biologics is if we give them a live vaccine, theoretically maybe they couldn't mount the same immune response and then they could really get the infection. So really important to remember no live vaccines. The other times that we would hold the biologic is if there's a new cancer diagnosis. We tend to hold it at that time, not to compound the toxicities associated to radiation and chemotherapy. But we do know that overall there's no increased risk of cancers except maybe a small blip on non-melanoma skin cancer. And so that's to reassure you, because 20 years ago when I started practicing and put these patients on biologics, I used to be able to tell them, look, we've got 5 years of safety, it looks pretty good, but I don't know in 20 years if a big Goomba is going to be growing, because we don't have that data. We do now have that data. We've got 20, 25 years of safety data. And what's also really incredible, when they came out with these biologic agents early on, there are certain countries like Sweden, Denmark, UK, they established what we call these registries. And so what we mean by that is every single patient who went on a biologic agent had to be registered on one of these registries. And they then were followed and are followed throughout time prospectively to see, is there an increased risk of cancer? Is there an increased risk of different things? And so these registries now encompass hundreds of thousands of people, and that's where a lot of our safety data is now coming from, and they look very safe. So we can reassure our patients, no big Goomba, there's no risk of breast cancer, there's no risk of colon cancer, there's no risk of other conditions. The risk is the risk of infection. So we do know that there is a slightly increased risk for that. The other kind of minor conditions, some patients do get injection site reactions. Most of the time, minor. We do recommend that patients take them out of the fridge, maybe for half an hour or an hour before giving themselves their injections. Sometimes that will reduce it. There are some patients who get infusion reactions, the ones that are getting it IV, but we can often, with some Benadryl or some Tylenol beforehand, can mitigate those symptoms. Perioperative management, so if you're going to go for an operation, knee replacement, gallbladder, whatever, and it's an elective surgery, we do recommend that the biologics should be held at least 1 to 2 weeks prior to the surgery. Then you go through your surgery and you wait 1 to 2 weeks. If things are good, there's no risk of infection, there's good wound healing, then you can resume it. So that's usually the guidelines that we use for biologic therapy. We are now using biologics as well. A lot of our patients, my young rheumatoid patients or lupus patients are in their childbearing years. And so there's a lot of research being done on using biologics during pregnancy and lactation. We know that antibodies do not cross the placenta in the first trimester. So therefore, there's no risk for our patients who are getting pregnant. And then the decision has to be made, do we continue with this even throughout the pregnancy, or do we hold it until they deliver? And this would be some of the discussions that we would have in the office with our patients and for long-term management. To get access, so as I said, they're very expensive, and that's probably one of the biggest hurdles that we have to do here. And I would tell you that access is a provincial type of determination. So it's different here in BC than it is when I was practicing in Quebec. So here in BC, there's a set of criteria. And if you say, been there, done that, I use methotrexate, I use leflunomide, then you fit these criteria, then we're allowed to apply pharmacare and they will cover you. When you are covered, you're covered for usually for 1 year, and every year we have to reapply. So there is a bureaucratic process involved to getting biologic agents. This would be a little bit what the forms would look like that we have to fill in, and looking at the different agents that have been used and explaining why they've been used, why they were stopped, was there any side effects. And if you fit these criteria, this would be then how we would apply for pharmacare to approve patients on biologic therapy. So now that I've talked a little bit about biologics, I also want to address the other therapies that are really, really important in the management of arthritis. And I would say that by far for the management of osteoarthritis, and for osteo I mean also secondary osteo, so the people who've had rheumatoid but their joints are now damaged, certainly physical therapies I cannot stress enough. You need to be working with your physiotherapist. There's many things that they can do to help you develop muscle strength, muscle balance, and compensation that will really help in the management of your symptoms. Orthotics are really important. Our feet, just as we age, change, but then you add rheumatoid damages to that. And if you've got a problem with the feet, the next thing you know, you've got problems with the knees and the hips and the back. And so sometimes people come in complaining of their back, and I'm looking at their feet, and they're going, no, the problem is in the back. And I'm going, no, the problem's in the feet. If we can fix the feet, we can fix the back. So make sure that these are things that also are really important in the management of arthritis. I think weight loss is very important. The more weight you carry on your joints, that will certainly hinder them and cause more grinding and damage. There is visco supplementation. I get asked this often. This is a bit like putting oil in your car, and it just kind of lubricates the joint and helps the joint move a little bit better. It's a temporary solution, but what it does is by putting this hyaluronic acid into your joint, the cartilage kind of soaks it up, and it's like a sponge that becomes a little bit firmer, and then for a while it works well. But with time, as you walk on the joint, then it kind of squeezes it out, and it needs to be repeated. But I do get some patients who get some favorable response from that. And then finally, there's surgery that can always be entertained, and there's different forms of surgery, everything from fusing a joint to replacing a joint to just scoping a joint and cleaning it out. So there's different surgical things that we can do that will help with joint management. But mainly, I would also like to leave you with the management of wellness. So there's not just the therapeutic management of what's going on with the disease, there's also the whole person that we have to look at. And there's many things, as I said, that affect disease and affect your response and your pain and your quality of life and so forth. We know that stopping smoking is a direct link to the development of arthritis, so we encourage our patients to stop smoking and lose weight. But I cannot stress enough how much regular exercise, eating well, and sleeping well. I call those my triad to wellness. If you don't sleep well, it doesn't matter whether you have arthritis or heart disease. If you don't sleep well, you don't feel well. You need to sleep well. If you don't eat well and you don't feed your body nutrient-rich food, your body is craving and you don't do well. And if you don't exercise, our bodies need to be stretched, they need to be moved, they need to be exercised on a regular basis. And maybe some of my patients have heard me say, you only exercise on the days you eat. That's every day, okay? If there's a day you choose not to eat, don't exercise. That's okay. I'm okay with that. But the choice is not, do I exercise or do I not exercise? You always exercise. The choice might be, to what intensity, what length of time. So every day you have to do something. It may not, some days that you don't feel as well, you might say, okay, I'm not going to do it as much. I might kind of back off a little bit, but you still exercise. And I will tell you, more often than not, at the end of your exercise program, you're going to go, wow, I feel better. This was worth it. I did it. And so exercise is really, really important. There's different types of things that you can do. There's range of motion exercise, just simply stretching. There are so many ways that you can access. You can go to classes, you can go, but even on YouTube. And I know that our younger generation, they all go on YouTube, but we're allowed to go on YouTube too. And there is so much resources there. Simple things like yoga in a chair. You just look that up. Just punch in yoga in a chair. You plunk yourself in front of your screen, and for 20 minutes, 30 minutes every day, you just do exactly what they're doing. And because I understand, I tell yoga my patients, but my patients will say, I can't get down, I can't get back up, I can't fold over. I'm not asking you to do kind of just sit down in front of the computer and do these range of motion exercises every day. They're very helpful. You want to do some strengthening exercises, and that's also important. Things like elastic bands. So the guys that go to the gym and do 50 of these, that's to bulk up. We're not looking to bulk up. We're looking to tone our muscles, and you do that through resistance. So resistance with a little bit of an elastic band, or Pilates, you know, where you just squeeze that ball between your knees. Your joints haven't moved. You have to protect your joints. So there's different ways of doing it, but you need to do a little bit of resistance. And I think 2 to 3 times a week, you should also be doing some kind of cardiovascular exercise. And that means, all that means is that your heart has to beat a little bit faster. Your breath has to be just going a little bit faster. You are now in an aerobic phase of metabolism, and that is a cardiovascular exercise. And you need to sustain that for 15, 20 minutes. And now you've done an aerobic type of exercise. So this is kind of the program, and you need to kind of plan it. You know, 1 day a week I'm going to do this, 1 day a week I'm going to do that. And you can work around these different parameters. And I can tell you, unfortunately, when people get sick, the first thing that goes is exercise, when it's the last thing that should go. So I really encourage you to be diligent, to be, you know, keep doing your activities, because that, beyond any biologic, beyond any kind of what we're going to do, that is what's going to keep you moving. And then I think I'll stop here. And I think we're not doing questions now, right? Okay. Thank you.
Thank you very much, Dr. Hudson. So one of the things that we wanted to talk about here today, too, is our volunteers and living well with arthritis and how they live well with arthritis. So we do have 2 volunteers who will be joining us to speak about their journey with arthritis. Our first one, Jackie Shinkuski, couldn't be here today. Some of you who have attended some of our workshops in the past have probably met Jackie, as she is a volunteer with our organization that leads those workshops. But she did prepare a video to show, so we are going to show her video. Jackie received her bachelor in education in 1988 and was a teacher until 2012. She's a musician and played with the Kamloops Symphony Orchestra. She's also an avid photographer and volunteer with both our organization, the Arthritis Society, and the Canadian Spondyloarthritis Association. She was diagnosed with ankylosing spondylitis in 2016, which is a form of inflammatory arthritis. So, are we good?
Before I begin, I would like to thank Linnea Westland and the Arthritis Society for asking me to speak here today, especially considering the fact that I was going to be away and they asked me to speak to you anyways. So here I am in my little video to you, and a big thank you to Linnea. I was diagnosed with an inflammatory arthritis 2.5 years ago. My arthritis is called ankylosing spondylitis, but I have lived with this disease for a lot longer than 2.5 years. I vividly remember my first flare at 14 years old. I was in excruciating pain. I could not turn my head nor sleep. It lasted 2 weeks. Attending school felt impossible. I knew this couldn't possibly be normal, and I begged my mother to take me to see a doctor. But she was not going to take me to see a doctor for a sore neck, and at the time, that seemed reasonable. From my later teens into my 30s, I constantly had visible problems that caused concern not only for me, but for bosses and doctors. I was referred to specialists and physiotherapists. In the end, it always came down to the fact that there was definitely something wrong with me, but I simply had to learn to live with it. In my early 30s, I was having difficulty walking, and I believed that if I accepted to simply live with this, that I would be in a wheelchair by 40. And that was completely unacceptable to me. So, with the help of a healthy dose of stubborn, a personal trainer, chiropractors, lifestyle changes, and a lot of ibuprofen, I was able to get from my mid-30s to mid-40s quite well. By the time I hit 50 years old, the disease was winning and I needed help. I went through my grief process, and with my healthy dose of stubborn, I found my ways to function well. I got rid of anything and everything that caused me unnecessary stress. I started tracking my health, exercise, fatigue, diet. I started a gratitude journal, and still to this day, at the end of every day, I write down 3 things that I am thankful for. I was struggling with things I could no longer do. So I created a can-do list, and I threw away the can't-do list. I focused on the activities that I wanted to keep and worked on modifications that would allow me to continue participating in these activities. Being able to continue playing my horn, including changing how I sit and how I hold my instrument. I carry an inflatable pillow with me in case the chair in the rehearsal room or performance stage is too big. The pillow behind my back allows me to keep my back against the chair and my feet on the floor. I started taking biologics 2 years ago, and I decided before I started that this medication was going to work for me. My thinking was that if I believed this medication would work, then my odds for success would be better. So far, so good. I continue to learn how to communicate well with the people I live and work with. I have learned to say, "Sorry, that's too much for me," or "I need a little help." I have come to accept that there are things that I have to let go of and let someone else do. I own my reality. It's no one's fault but mine if I do too much and I'm unwell. I have learned that anyone who doesn't like my decisions doesn't matter to me, because I am the only one who has to live in this body. I am the only one that knows how it feels, and honestly, I like to feel well and able. Today, in 2018, I am proud to say that I am working. I'm working for my husband's company out of my home office with my sit-stand desk. Even if I'm having a bad day, I can go to my desk in my PJs. I make sure that I eat properly and regularly. I have a daily goal of a minimum of 30 minutes of exercise. Water exercise makes me feel the best, and to ensure that I don't get too cold, I wear a long-sleeve swim shirt and water shoes. I also go to the track at the TCC, walking and using the hydraulic machines, because two-way exercise is what works best for me. A year ago, my husband and I started playing pickleball. And if you have a natural competitive nature that you need to satisfy, this might be the game for you. And if I simply can't fit anything else into my day, my bare minimum is 30 minutes on my treadmill. All exercise I do is followed up with a good stretching or yoga session. I'm still playing my French horn in a brass trio and brass quintet, as well as playing in one orchestra, if a horn is needed, but only one. Whichever group asks first is the group I play with. When you are at the beginning of your diagnosis, treading water while the waves crash over your head and toss you around, from doctor appointments to tests to scans, it all seems so overwhelming, and you are looking for anyone who can help you manage. Many of us face diagnoses of diseases that we've never even heard of, never mind knowing how to live with them. It's a process, and we need to be patient with ourselves. All of our roads are different, and what works for one won't necessarily work for someone else. Many things play into this, including personality. Let me just say that any amount of stubborn goes a long way. Take your doctor's advice. I'm serious. Follow recommended treatments, keep track of how you're doing, and let them know the results, good and bad. Finding the treatment that works for you is what's important here. This is all about you, and you need an open and honest relationship with your doctor so that you feel and live as well as possible. If you are experiencing serious problems in between appointments, make sure you make an appointment to go and see your doctor. If you are traveling and forget or lose your medication, get in touch with your doctor. Medication should help, but it is not a cure-all. If we want to live well with arthritis, we need to move and we need to eat well. Presently, there is more and more research coming out on the microbiome and how it influences inflammation and joints. Find exercise that works for you and start where you are comfortable. If that means 10 minutes.
Putting that together. Our next speaker is here with us today. Diagnosed with psoriatic arthritis when she was just a teenager, over the last decade, Samantha Kampman became a University of Alberta law student and then a lawyer for I can't say it, I'm sorry. Lawyers and CAMIPs. Samantha's personal experience with arthritis, including sharing her diagnosis with her younger sister, inspired her to join the Walk for Arthritis in 2017 and 2018. Please join me in welcoming Samantha.
Thanks very much. It's Gillespie. All right. So I was 16 when I was diagnosed with psoriatic arthritis. And for me, it was like my life was over. I did not manage well for about 3 years. I was depressed. I was in an extreme amount of pain. I tried a lot of different medications that had a lot of different side effects. And it was really not a good time in my life. Today, I have been asked to talk about how someone living with arthritis can empower themselves and work with others to better self-manage their own arthritis. I'm going to tell you how I've been able to do that. So, about 3 years into my diagnosis, I was given the opportunity to try a biologic agent. And around that same time, I decided that it was time to take my health seriously. This was a disease that I was going to live with forever. And I wanted to take some control over it. Living with a chronic disease can leave you feeling helpless, and things happen and you feel like you have no control. But you can empower yourself by focusing on the things that you can control. Every little thing that you do helps. It all adds up. Medications are just one component of that. There are so many things that you as an individual have control over. And Dr. Hudson and Jackie have both talked about this a little bit. And I'm going to tell you sort of my experience. Number one, exercise. This is one of the most important things. You might have to adapt. You don't always have to do the same things you're used to doing. I used to be a runner. I love running. Right now, I'm going on 2.5 years since I last ran outside. For the last 10 years, there's been periods where I can run and periods when I can't run. And when I can't run, I have to do other things. I have to adapt. 2 weeks ago, I bought myself a mountain bike, and I'm gonna start doing that. It's 1 day at a time, it's 1 week at a time, 1 year at a time. You just have to do what you can do right now. So right now, that's a bunch of low impact cardio, and it's weightlifting, so you can find me over at the TCC, working out. It's a long-term lifestyle thing, and you can't think of it as a short-term solution. It's a long-term change, and you have to be committed to it, and you have to enjoy the activities that you're doing. Another thing is diet. That's pretty self-explanatory. If you eat healthy, you're gonna be just better equipped to deal with all the things that your life throws at you, including your disease, any infections you might get if you're immunosuppressed, like I am. Eating healthy is gonna help that a lot, as will getting enough sleep, and that is also super important. I find when I don't sleep enough, I get stressed more, I have more anxiety. This leads me to have more arthritis flares, which in turn causes pain and more stress and anxiety and poorer sleep. And on the flip side, when my arthritis is flaring up, I tend to get more stressed. It's all a big cycle, and you have to try to break that cycle. Do everything you can to try to break that cycle. So on a related note, mental health is huge. Huge for people with chronic diseases, huge for people with pain. It's so closely tied to your physical health. If you are not mentally well, if you're depressed, if you're anxious, if you're stressed, you're not going to be physically healthy either, and vice versa. So it's very important to reduce your stress. I have a stressful job. I'm a lawyer. I have to remember that my health is the #1 priority. So am I gonna work 2 more hours, or am I gonna go to the gym and then go to bed early so that the next day I wake up, I'm refreshed, I'm not as stressed. It's not a short-term thinking, it's a long-term. So that's huge. Mental health is huge. All right. Another thing I want to talk about is communication. So important to inform yourself about your own disease. I think it's great that there's so many people here today. I didn't expect this big of a turnout. So I would recommend that you learn as much as you can about your disease by coming to things like this, reading about it, ask your healthcare providers questions, ask them for clarification. I know sometimes as a patient you can feel a little nervous, you can feel a little intimidated, you don't want to ask certain things. Just do it. Most of the time, I've found your doctors, your pharmacists, they're more than happy to help you and answer your questions. Educate others. People don't understand what arthritis is, this broad range of diseases that arthritis is. They're not going to understand when you tell them, I have X. It might be totally different type of arthritis than something they're familiar with, or they might not be familiar with arthritis at all. So it's important to talk to people, inform them about your disease, to build awareness and understanding, not to make excuses. And I know sometimes people are hesitant to talk about their disease because they don't want to be seen as whining or complaining. In my experience, if you approach it from an educational standpoint and you're just trying to bring awareness, people are really supportive, really sympathetic. I've had this experience, for example, in my employment. There have been instances where my arthritis has affected my work or my ability to be at work. And when you just explain to people what's going on, most people are usually really good. And I think it's super important to find support in your community with your family, with your friends, and then more generally in the community. So for me, my family is my lifeline. My husband drags me to the gym when I don't feel like going. My sister, as Ashley mentioned, she also suffers from psoriatic arthritis. So it's really great to have that person to talk to who understands what I'm going through, and we can sort of just make each other feel better that way. So finding people that you can connect with on that level, I think is really important. And it doesn't have to be people with your exact same disease. I also have friends that have various other chronic diseases, and it's just nice to have that support and know that other people out there are dealing with similar issues that you are. You're not alone. And so on that note, I have also been very involved the last couple years with some people in the Kamloops community. And as Asha said, I've joined the Walk for Arthritis, and I found that is very nice in terms of feeling the support of the community, other people that also struggle with arthritis and also want to get out there and talk to other people that deal with some of these issues. So just to finish up, everybody's going to have setbacks. I mean, you're not going to go work out every single day. There's going to be days where you don't. There's going to be maybe a week where you don't. You can't let that bring you down. You have to get back up and carry on and think of it as a long-term thing. How do you want to live your life? Do you want to feel well? Do you want to be happy? And try to have these support systems in place so that when these things do happen, you can turn to your family, you can turn to your community members, you can fall back to your established exercise and eating patterns, and you can use those to sort of help you through the hard times. And I have found that this has worked really well for me. Most recently, I was diagnosed with Crohn's disease as a further manifestation of my arthritis. And that was a few months ago, and it was really hard. And there were a few weeks where I did not take my own advice. But having built up these systems for the last 10 years, it was much easier to bounce back from that than it was the first time around. And I think that that's really important. So, thank you.
Thank you very much. So now we'll take a 10-minute break. Let's see what time it is, so we come back and start. We will come back and start again at 2:25. So everybody, please feel free to take a break, stretch, and grab some coffee back there. Okay, I see everybody's making their way back to their seats. That's great. Such an on-time crowd. I appreciate it when people listen to me. It doesn't happen very often. If you could tell my 18-month-old and my 4-year-old that would be great. All right, I will do my introductory talking while people are making their way back to their seats. The first thing I did want to do is acknowledge again that we couldn't be here today without the support of our sponsors. So thank you to our sponsors who are listed on the screen right there. So, Dr. Chris Spooner received his Bachelor of Science in Biology from the University of Victoria in 1991 and his naturopathic doctor from the Canadian College of Naturopathic Medicine in 1988. Or 1998. He is the Vice President of the Board of Directors of the College of Naturopathic Physicians in British Columbia and is on faculty at the University of British Columbia, Okanagan, and the Boucher Institute of Naturopathic Medicine in Vancouver. Dr. Spooner has focused much of his practice on medicinal cannabis, and we are fortunate to have him here to share his knowledge with us. Please join me in welcoming Dr. Spooner.
See how that works. Good. All right, we're trying new technology here today as well, too. So I'm one of those Mac users, so whenever we put Microsoft and Mac together, sometimes they don't play quite so well. So here's hoping. So, cannabis. This is an interesting talk. So many people, I think we're entering into this really brave new frontier. There's a lot of curious patients out there that are asking about this. So it's timely and interesting. Frankly, as we move forward, a lot of unknowns, a lot of confusion. So what I hope today is kind of touch a little bit on how it fits into arthritis care, talk a little bit about what patients are looking for when they're doing this, and also give some ideas of, as we move forward to legalization, what that looks like. But I can tell you, there's a ton of misconceptions about what medical cannabis is. And obviously it's been stigmatized, I think it's been used and abused for many different ways, but there are many different patients. The patients that you think are using them, the demographic that you think that's using cannabis would probably quite surprise you. So just to give you a little sense of where I came from on this, you may tell I'm not your typical cannabis type person. Thank you. I fell into this actually because it was driven by my patients. And I think the other interesting thing about actually being invited to come here as well too, which I'm incredibly grateful for, because one of the things is it's nice to be able to talk about naturopathic medicine and put it in a proper context, because I think when we start to talk about this, we realize we actually share a lot more similarities in what we're actually trying to take in our approaches and how we're trying to help patients than we have differences. And just hearing things about diet and exercise and nutrition, microbiome, these types of things. These are all the little, play areas that I get to work in every day. So it's nice to be able to share that information and start to find out where the overlap is. And at the end of the day, it's really about helping patients sort of navigate through this, because really at the end of the day, this is about patients. And we really try and encourage patients, I really try and encourage patients to make sure that we're part of a working team, that I have good communication with their medical doctors, and that their medical doctors are encouraged to talk to me as well too, because at the end of the day, we want to be more integrative. Naturopathic, I don't know what many people think naturopathic is, but I really look at it as integrative. We start with the basics, we choose the least toxic, least invasive way forward, and then move forward and progress from there. Many people don't even realize that naturopathic doctors have prescriptive authority. I can write prescriptions. I can order blood tests. It's not covered by medical, but I can do these things. But we don't use that as a first line of therapy, and many of the times we're trying to work on these sort of baseline, base formats of health, trying to do these underlying determinants. So like I said, it's a really great opportunity. And certainly cannabis is an interesting one because one of the things that we often see with naturopathic medicine is that we're often kind of really at the pointy end. Patients are coming and asking us about things. If you take a look at some of the areas that many people probably know a lot about, think about omega-3 oils or vitamin D or probiotics and microbiome. Well, these have been things that we've been working with for the better part of 2 decades since I've been in practice, right? The challenge is that the evidence base, the research of that has to accumulate, it has to build over time. And so sometimes what we're seeing patients driving this forward with, we sometimes have to be in this sort of evidence-free zone. And cannabis exists exactly in that space right now. And in fact, it's always funny, I joke with when I do these things, is that it took cannabis to make people believe that herbs actually have medical value, right? Oh, is that better? There we go. Perfect. Better that way? Ah, there we go. Okay. So, that being said, let's, I'm just going to get my thing going here quick and we'll start talking about some slides here. So, technology. There we go. So let's talk about what we want to talk about today. So let's talk about why patients are using cannabis. Let's talk about the science for cannabinoids and arthritis, and let's talk about legalization and the basic things that you could be looking for, okay? So who's actually using cannabis? So this is actually data taken from Health Canada, okay? And I think most people would be surprised to see that 36% of your people are actually using it. It's the largest user group for cannabis. And people are using it in numbers of different ways. In my experience, in my practice, I did a talk 4 years ago on this, and we had over 400 people in Vernon at the Prestige Inn. I would say we had maybe a dozen people under the age of 50. Okay, everybody else is above. And the fastest user group in terms of cannabinoid therapies is definitely 60, 70, 80-year-olds. I've got 84-year-old patients coming in saying, my nephew or my grandson brought me this stuff. How do I use it? And you're like, okay. And again, that creates some problems. And I'll talk about this a little bit later on because cannabis is not just cannabis. There's a number of different compounds in it that you need to be aware of. So Dr. Hudson touched on the arthritis. I don't think I'll reiterate any of that. I'll just draw your attention real quick too, is that if we take a look at things like osteoarthritis and we take a look at rheumatoid arthritis and the cartilage, that's actually, we're seeing some very interesting stuff about cannabinoids and what are called endocannabinoids and receptors. These are things like locks and keys. So basically what happens is that key goes in, binds with a receptor, and it turns on a certain process. And the cannabinoid receptors, we're actually seeing quite a few of them in cartilage and bone and joints, okay? So we'll belabor that. Let's talk, I won't go into this much as well too because Dr. Hudson, went on this, and I have a tendency to make a ton of slides, so I mean we could go on forever, but we'll just skip through the quick ones here real quick. Same thing with the current pharmacological options. We've got the NSAIDs, you've got the opioids, you've got steroids, you've got injections, and you've got the biologics. Again, I'm not adverse to any of these. I actually prescribe some of these for patients, and many people are surprised to hear that as a naturopathic physician, I would actually be recommending these to these patients. And in fact, the biologics, I love the biologics. I think these are fabulous drugs, and they can work very, very well for patients. And I think they're targeted, the side effects, and the faster that they could actually get patients onto those, I'm completely in support of that, But I do find that there are sort of these little things that get missed. There's gaps, and again, the exercise and the personal care and the wellness care and these types of things, those start to become really important elements for this as well too. Certainly one of the big things that we take a look at when we start talking about pain treatments in particular is just there is some hazards with these things. If we take a look at some of the major rates for hospitalizations for things like gastrointestinal bleeds, that's ibuprofen and your NSAIDs. If we take a look at, things like the opioids and the concern about opioid use, I mean, these become real issues that, can we be looking for other alternatives? And I should say, cannabis is being looked as one of those opportunities. And certainly when you take a look at the sort of the discussion that's happening around it for pain use, I mean, there's myself, and I work with many other. I work with internal medicine doctors, oncologists, pain specialists as well too. And we constantly say, in the guidelines, they suggest that cannabinoids be the last used therapy after everything else has gone out or been tried. Where in fact, they're actually, if you take a look at some of the safety profile of this, and if you look at cannabis here, I mean, to actually take the amount of cannabis that they calculate, I mean, you would have to inhale almost 1,500 pounds of cannabis in 15 minutes to get a toxic dose of that. I mean, I just don't think that's, I mean, it's impossible. And when you take a look at the way that you can dose it in terms of oral dosing versus, the inhaled dosing, I actually recommend patients do more of the oral dosing, but there are strategies that you use as to why you would use one for the other. And certainly I'm not a big fan of smoking it either. I'd much rather see patients vaporize it. And that's a very different, it has a very different impact in terms of carcinogenic exposure, et cetera, et cetera. So ideally, if we take a look at this, if you take a look at how long cannabis has actually been used, I mean, just take a look at Northern California. I mean, we've had 30 years of millions of people using this stuff. And are we running into some problems in terms of cannabis abuse disorder and these types of issues? Yes, but I think we also have to put things in context and say, how many problems do we have lots of other medications as well, too? And I think as we learn more and more about how we dose this, about getting products that are standardized doses, that actually we know how much we're getting of the different compounds within it, which is what Health Canada has set up, that's going to make the difference. The biggest problem is just, people walk in. I mean, it's amazing what people come in with. I get people coming in with these syringes or bottles, and it's like this thick, tarry stuff. And they're like, I take the tip of a toothpick on this. Right? And if I take more than that, I'm higher than a kite. And you're just like, that's a dosing strategy. And it's because we haven't got a manufacturing process that makes a consistent product that we have that. If you go into one of the dispensaries, God knows what you're getting. And we'll talk about that a little bit later about what that's going on. But suffice it to say, if you take the approach of starting low with your dose, going slowly with it, focusing more on the cannabidiol, which is the non-psychoactive part of it, and being very, very conservative with THC dosing, you can use this very, very effectively, okay? So, now many people don't actually realize that we actually make our own cannabinoids. How many people had any idea that you actually make your own pot in your body? Yeah, in your body, absolutely. They're called endocannabinoids, endogenous cannabinoids, okay? And this is really interesting because what we're finding, they're called anandamide and 2-arachidonyl glycerol, okay? And the molecular structure of them right there, I find it fascinating. You may be like, what the hell is that? But one of the interesting things about this is the molecule itself actually looks a lot like some other compounds, and they're the compounds that control inflammation that are derived from the fats in our bodies. So many people don't realize that when you take an omega-3 oil, you make a specific type of molecule that actually is anti-inflammatory. If you eat certain types of oils, like saturated fats and animal fats, you make a signal that's pro-inflammatory. These are called prostaglandins and eicosanoids. And so these are part of the fatty acid metabolism. And so when you talk about things like diet, what do we want to be looking at? Well, everybody's like, well, I'm going to take, how many people focus on the fats that they're eating? Well, I eat lots of fresh fruits and vegetables. I try and stay away from certain foods. But how many people are actually really thinking about the types of oils that you're eating? Because those shapes, I always use the description, the coat hanger, you have that 2 darn bends in it when you're trying to unfold it to open up your car because you've locked your keys in it. You've got those bends in it, and these molecules have those bends that your body works around to make these other molecules that become these signaling molecules. So the really fascinating thing about your endogenous cannabinoids is that they are byproducts of fatty acid metabolism. And so they do all sorts of really interesting things. And in fact, we had no idea that this endocannabinoid system actually was there. It's a new discovery. How we missed it. It's more prevalent than the opioid system in your body. It controls almost every function of your body. So one of the really fascinating things about this, and I'll get into a little bit of some technical stuff here, but it's what we call a retrograde signal, okay? And this is, we're getting some adjustment on the sound there. I'm probably moving back and forth from that. But 2001, some of the first high impact publications were actually showing that these signals were being generated out of your nerves. Now, I don't know how many people know about nerve actions, but basically you've got these long, hairy little things that stick off the end, and at the end of them, you release neurotransmitters, and those cross a little gap, and that carries the electrical signal on to the next nerve. It's called a synapse, okay? Well, the interesting thing about the cannabinoids is that they're actually not made at the end of the nerve. They're made by the nerve body, right down in through here, which was really, really, really unusual. And then the other thing that we started to see was that these things actually modify the nerve impulses. They actually act like circuit breakers. And the term that we use for that, well, I'll talk about that one actually, it just revolutionizes things. Let's talk about that. Because what it does is it means that we used to think that your nervous system was like the electrical cord. You plug it in, but you can't plug the two, you have to have one end lead to the next, and it only goes one way. What we're finding now is that this cannabinoid system modifies the signal and can actually send signals backwards in your electrical cord to modify the electrical signal as it goes through. So what these end up becoming are what we call retrograde signaling molecules, and they modify and they're balancing. And one of the things that gets lost about cannabis is that if you're too high, it brings things down, it changes signals, and if you're too low, it brings things up. They don't push really hard, they're balancing. They're like a thermostat. And so at some point in time, you don't need to use massive doses of these things to modify the effect. And you can just get this slight balancing, regulating function that happens. And that's the role of the cannabinoid system in our body. They're regulators, And so this was revolutionary, okay? Now, the other thing that we thought was what does this stuff interact with? Well, it turns out it interacts with everything, okay? And again, this is a lot of molecular stuff here, but these are plant cannabinoids. And the plant cannabinoids bind to receptors that the endocannabinoids work with. So it's just, if you think about this is kind of an interesting phenomenon. Like think about there's a plant that's been on this planet that we have almost co-evolved with. We have a plant that inserts itself into our regulatory processes in our body in such a way that it has the impacts that it has. It affects our physiology so interestingly. And again, it's a little bit of a like, whoa, So, and it's funny because many people think it's just cannabinoids that do this as well too, but we're also learning other plants make other cannabinoid-like substances. How many people have ever taken echinacea? All right, well, congratulations. You just took an alkemide, which is a cannabinoid-like compound. It binds with a cannabinoid receptor. Didn't know that. How many people like black truffle oil? Not too many. It's a bit pricey. Well, there you go. Well, it's also a cannabinoid receptor. Black pepper, clove, wild carrot. What else could we go on with? There's a host of other ones as well too. Kava, some of these medicinal herbs. But what we're finding now is a lot of the medicinal herbs actually act through the endocannabinoid system. So again, it's one of these things that when I do these presentations, I was just out in Montreal presenting to the Multiple Myeloma Society. And I think for the medical doctors is they struggle to kind of sort of wrap their head around a plant-based medicine and how complicated it is and all the rest of it. It's actually, we're already using it. It's already part of the physiology. We just need to understand the dose, and we have to have forms that are available so we can start to understand it a little bit better and be a little bit more directed in what we're doing. But this isn't a big, scary plant. The reason that it's scary for most people is because it's been used and abused. It's been used recreationally. But I mean, there's many things that we use in similar ways in our society that we really don't have a problem with that are socially acceptable, whether you talk about alcohol, whether you talk about cigarettes, maybe less so, whether you talk about coffee, chocolate. Chocolate has, all of these things, they fit in there and they work in similar types of ways. But if we can just figure out, get the dosing down, that becomes really, really important. But one of the interesting things that we take a look with this is that we affect things like COX, cyclooxygenase. That's what your NSAIDs use as anti-inflammatories. It blocks that pathway. There's your opioid receptors. the 5-HT receptors, we're actually looking at doing some work with one of the groups that I work with. That's one that regulates nausea, and we're looking at trying a study of using the non-psychoactive cannabinoid, cannabidiol, to reduce nausea in patients taking methotrexate so that they can stay on their medications. If we take a look at things like TRP, TRP is what we call a TRP-V receptor. This is one that actually is a nerve pain, and I'll show you why this one's important. But anybody who's ever had shingles or that burning pain, and then you take and put like the capsaicin rub on it, the hot pepper rub on it, you're actually activating a TRP-V receptor. And that is one of the things that cannabinoids actually work with as well too. So as we start to learn more and more about what's happening in this, we see that it actually works, it's opening up our understanding of a lot of other different processes and diseases. This was a picture, an image that came out of Trends in Pharmacological Sciences. It was done in 2012. And the interesting thing about this is it talks about sort of the multiple different areas that you see being affected by not just cannabinoid, not just CBD or THC. Most people are familiar with the THC, but you see the big blue one here. This is your cannabidiol, and it's got impacts on neuroprotective, epilepsy, blood vessels, mood, sleep. If you take a look down here, there's some immunosuppressive and immunoinflammatory based on the tumor necrosis factor, TNF-alpha. So the cannabinoids actually interact, with some of those very same signaling systems that we're actually seeing involved with arthritis. And again, it's not just the sort of the big compounds that we hear about the most. There's a whole other assortment of different compounds. And these compounds react with receptors. So the first one is what we call the type 1 receptor, okay? And the type 1 receptor is basically what binds THC. And THC is the one that gets everybody a little bit giddy and happy and munchy, right? And the reason that it does that is because this receptor lives predominantly in the central nervous system and on nerves. So when it has an impact, it's changing all of those nervous pathways. And so that's why we end up seeing these changes in euphoria and mood and that, just the way as we would see, an antidepressant helps elevate mood. I mean, it works on that synapse on the similar type of, in a similar fashion. And one of the really interesting things that we're learning is that your tolerance for this compound changes, and we find that older have different responses than younger, and it changes. And in fact, many patients could derive some of the other benefits of the THC molecules, like the nerve function and anti-anxiety and sleep part of this, without necessarily getting the high from it because of the change in the nervous system. But it goes even further beyond that as well too. So I mean, if we take a look at what else, we're seeing information in the pancreas, blood sugar control, diabetes, in the liver, things like fatty liver disease is becoming something that we're seeing some interesting things with. Adipose tissue, the cannabinoids regulate metabolic function and stimulate weight loss. The gastrointestinal tract and the gut microbiota, a huge area. There's so much stuff going on with the microbiome, and to suddenly see cannabinoids slotting right in there is really quite phenomenal. And then in the muscle as well too, we're seeing some things there. And that's the THC molecule that's in CB1. If we talk about the other receptor, which is called CB2, the CB2 receptor binds the non-psychoactive cannabidiol. And this one's found predominantly in your immune cells. So cannabidiol actually has much more anti-inflammatory effects. Okay, it acts to suppress inflammatory systems or to regulate inflammatory signals, the cytokines, interleukin-6, interleukin-2, tumor necrosis factor alpha. And the interesting thing is it is this balancing effect. Like, it doesn't shut it down and it doesn't ramp it up. It finds that happy medium in there as well. And the thing of it is that once it's stopped doing its job, or once it's reached the set point, it really doesn't do anything anymore. It just kind of leaves it there. That's what we refer to as this sort of inducible, okay? So again, these molecules that your body actually puts out, and these receptors that then upregulate as you need them in an effort to try and maintain balance or homeostasis. So if we talk about what cannabidiol receptors do, or CB2 receptors do, they are non-psychoactive and they have this anti-inflammatory effect. So I've seen many, many patients that come in. Now, I can't actually authorize cannabis for patients. My license doesn't allow that. As things changed on the 17th, you know, the recreational market and all the rest of that, we're still trying to figure out what that looks like, because it's not clear. But long and short of it is, I've seen many patients that come in with just a CBD oil, and they have remarkable results, you know, in terms of just sort of settling down some of the pain. And I'm going to talk a little bit about why that might work this way. So it starts off with research that's been done just taking a look at endocannabinoids and what they do in arthritis. And what we end up seeing here is that it changes what we call nociceptors. So nociceptors are these little nerves that measure movement, and they're vibration sensors. And so one of the things is that if you get that little tweak in the joint and, oh, it hurts, that's a nociceptor, okay? And what they did with some of this research is they looked at biopsies that were taken out of surgeries. So when you did the total knee replacement, they said, okay, well, let's take a look and let's see if we can find these receptors. And they found tons of them in there. They found in both rheumatoid arthritis and osteoarthritis, both of these cannabinoid receptors in higher amounts. And they actually found that within the joint space, you actually had, in people who did not have arthritis, they didn't have elevated levels. But in people who did, you saw these levels ramped up. And again, the hypothesis is, and what we're understanding, is that it's working to reestablish a balance. So those levels start to come up in an effort to try and modulate the effect within the joint. So this was some work that was done by Dr. James McDougall. He's out of Dalhousie University, and I've got some other slides from him. But all the little arrows that he's got here, this is actually cartilage, and it's been stained with an immunofluorescence. So they've been able to target antibodies in and start to identify the receptors. And lo and behold, they found receptors in the joint for THC. They also found it with this one for cannabidiol, for the CB2 receptor, and also this TRPV1 receptor. And what you're seeing here is sort of the differences in the synovium, which is the sort of softer tissue, and then the bone part of it. But you can see where these colors, the green on the top is the CB2 receptor, the red here and the second ones right here is the TRPV1 receptor, which is the driver for pain. And then you take a look at them when they live together, and you can see how closely they're all approximated. So this is work that was just done back about 8 years ago in 2010. So we're actually seeing these things, and Dr. McDougall is doing some really interesting work with this. And what he's finding is you know, this paper here talks a little bit about tissue engineering and cartilage, and can cannabinoids actually help with this? And one of the things that we're finding is that osteoarthritis is this process of build up and break down. So it's a balancing act that starts to happen. And what happens is that we often see sort of an elevation of these disrepair factors. So the breakdowns happening faster than the build up. And that's driven by a lot of these immune signals, these cytokines that drive inflammation. And when you put the cannabinoids into the mix here, it starts to shift that balance again as well too. When we talk about preclinical studies are things like animal models. So we're doing rat studies or test tube or this type of thing. So it hasn't moved into clinical. And that's one of the challenges, is that, you know, I mean, as we're moving forward, we'll see more clinical trials, but we've never been able to use it because the substance has been illegal. So there's no way you can put people on it. And if you talk with people down in the United States, for example, they have to go through these massive hoops. Like in order to do a study on cannabis, you have to have a safe in your research site. You know, the patients have to come in. They have to have like these apartments where they use it. They're there until it clears, and then they come out. But as we open up with legalization, we'll start to see more and more of this starting to happen. But again, there's other compounds. When you take a look at this, you know, cannabidiol, agulamic acid is a compound that's from another plant, but it also has effects on immune regulation. You know, and these ones here, HU320 and WIN55212-2, rolls off the tongue, you know. All of these are synthetic variants of this, and so they'll use things that are called agonists. When you hear the term agonist, it means it binds to the receptor and stimulates it. And the really interesting thing that we see about the synthetic cannabinoids versus the plant-based ones is that the plant ones always seem to work better with less side effects. You know, they're much more nuanced in their use, and we've seen many cases where there's been a synthetic version that's put out and people don't like it. And if anybody's ever used something like nabilone is one of the synthetic THC molecules, and people find it has horrible side effects. They feel nauseated and they get really affected by it. But that's because the receptor is really, they bind really strongly together. And so it never lets go, and whereas the other ones are much weaker, they kind of ping pong off a little bit more. But we are seeing more and more of this data starting to come. You know, we do have this drug. Yeah, this is in Spanish because I did a talk down in South America, and so I used a Spanish one, and I couldn't find an English one, actually, believe it or not. But this one here is a 1-to-1 ratio. So this was a drug that went through the drug approval process. It's called Sativex, or nabiximols is its other name. And basically this one here has 2 milligrams of THC, 2 milligrams of CBD, which are really, really low dosages for the most part. I mean, CBD, it's really low. The THC is maybe a little bit higher. And it has plant extract. But this is actually a standardized plant extract. Okay, you could actually go to, I mean, many of the licensed producers are actually making a product like this now in their oils. It's a 1-to-1 ratio of a plant extract. But this one's gone through the drug approval process, so it's about 10 times the cost of what it would be for that. So as this starts to move forward, but it's really interesting because when you look at the research, everybody say, well, Sativex does this, but the plant-based one can't do it. And it's like, but you're talking about the same thing, you realize. And it's one of the confusion that starts to happen when we take a look at the research, is that we start comparing apples to oranges, and we don't know when we're talking about the same thing. And again, that's a whole other different conversation, but I would suggest to you that there is, you know, as you're looking, or if you are looking or interested in cannabinoid therapies, you need to understand how much THC is in it, how much CBD is in it, you know, how concentrated is it, because those become the factors. Because for many patients, like I said, I've had patients that have gone in and they go into one of the dispensaries, which are technically illegal, just so everybody knows. They'll go in there and somebody will say there and they say, oh, I have problems sleeping. Well, why don't you take this gummy bear, right? And you should take a half a gummy bear or a quarter of a gummy bear. And everybody's like, well, you know, really? Half a gummy bear? Who's going to do that down the hatch? Well, most of these have 10 milligrams of THC, and most people will definitely feel that with 10 milligrams of THC. And especially if you've never used it, and especially if you're a senior, okay? And so suddenly you'll have someone go in, and the problem with it is that people adapt to THC. How many people have been following this concern about, they've been talking about impairment and driving. Have you been listening to that? So it's an interesting argument, because what happens is people get used to THC, and you can actually take quite a large dose of it and not be affected by it after you've been using it for a period of time. But if you stop taking it, it'll all come back and you'll get that effect again as well too. And one of the challenges that we run into with patients is that many will sort of chase the feeling of THC because they think that's what's doing it when it's really not. And you can actually use a much lower dose without any side effects that you would normally associate with THC and still get the pain relief or the sleep or whatever have you. And so it's just a matter of finding the right dose. But many people will use things like these incredibly concentrated THC derivatives because their thresholds are so high, and they're just trying to chase that particular feeling because they've associated the pain relief with a feeling. And they're you know, they happen together, but they're not cause and effect. So we're starting to see some research coming out here about in CBD and arthritis. This was a study that was done with that Sativex product. I have no financial arrangements with that as well too. I just mentioned it because it's the only drug that's approved right now. There's a new one coming out, but with these patients, 58 rheumatoid arthritis patients noticed pain relief, improved sleep, less side effects. And again, we need more clinical trials on this, but this is something that we start to see. But this is a formula that has a little bit of THC with it. There's another one coming out from the same company called Epidolex that's now been approved for seizures and what's called Dravet syndrome. But the CBD doesn't have the psychoactive effects that you would see. So many times what we find is all of these side effects that people complain about are too high of THC to start off with. And if we could start with CBD, that starts to make, you know, the difference, and patients can step into that a bit more. Some really interesting things that we look at. This is actually some images from inside the joint. And it turns out you've got these nerves in the joint, and what ends up happening is they're kind of like these electrical cords. They kind of get stripped, and they start sending out all these electrical signals. And you can actually see, if you look really closely, there's a thickness in what we call the myelin sheath, so the little sort of outer layer that insulates the nerve. Well, it actually turns out that there's a degeneration in the myelin sheath of these small nerves within the joint that then drive this TRPV1 pain response. And it's really interesting because this was work that Dr. McDougall did. They found that when they used the CBD and some THC with that, you actually saw a repair of that myelin sheath and the nerve signal came down. So this was one of the studies that he actually did. And he was out in McMaster at a conference I was at last in February. But basically, when you take a look at the pain signals that come, you get the nervous signal within the joint, you get this little nociceptor, it sends a signal out that goes into the spinal cord, and that goes up into the brain. And what happens is when you get more stimulation of that nociceptor, it ends up causing this little spike in activity, which then drives you the pain. So he did a really interesting set of experiments where he said, okay, well, let's take and look at CB1, which is, you know, a THC. He used a synthetic version of this. And you could see that with the control, all these little spikes that started to happen right here, those are all pain signals that are coming out. And so when they put in the THC analog, you can see that the pain signals started to drop off. So we started seeing that, wait a second, this is different. It is actually working on the nerve and the nerve signaling. If we took a look at this other one, this was one with CB2. Now this was interesting because this is a case where they used this GW405833. I was just at this conference in Amsterdam, and it was quite funny because all the people, you have 10 minutes to talk, and they roll off like these big, you know, 4, 5, 6, 7, 7, 2, 4, 4, 3, 1, right? And you're like, okay, we could probably condense the talk a little bit by reducing the numbers. But what happened here is the synthetic one actually created more nerve signals, okay? And the interesting thing about it was that it started to conclude that actually the pain relief that comes from cannabidiol has more to do with this other receptor through TRPV1, and it doesn't actually bind with a cannabinoid receptor. It binds with one of these other ones. And so again, this is the same one that we use with, you know, like I said, chili pepper binds to it. So when you use that type of a rub on it, or a heating rub, Tiger Balm, which has a lot of that type of stuff in there, that's working through these TRPV1 receptors. There's some interesting stuff about, if anybody's looked at prolotherapy with the dextrose, the sugar injections, it turns out that Dr. Dean Reeves out of the University of Kansas has shown that the sugar actually binds to the TRPV1 receptor and settles down the pain. So there's some interesting stuff that goes along with that. But what he did find is when you actually used CBD, the natural form of it, it actually reduced the signaling because it now acted on the receptor. So this is the type of stuff that we're starting to see, you know. THC, what's coming out is we're getting analgesic, we're getting these muscle relaxant effects, anxiety, antidepressant. It is psychoactive, so you have to watch the dosing, and an anti-nauseant. The CBD, anti-inflammatory, analgesic, anti-nausea, anti-anxiety, antipsychotic, antidepressant, you know, may counteract the THC. So one of the things we often find is that if you can have a little bit of CBD on board, patients don't feel the THC as much. And you can actually, if you give somebody a dose of CBD before they take THC, they don't get the impairment that you would see. So the ratio of your cannabidiol to your THC influences the therapeutic effects. And that's not to mention the other sort of 500 different compounds that are in the plant, and particularly things what we call the entourage effect. So cannabis also makes lavender oil, it makes lemon peel oil, it makes black pepper oil, it makes clove oil. I mean, there's a whole bunch of these other things that are part of the fragrances that actually have therapeutic effects as well too. And if anybody's ever smelled cannabis, there's a different range of smells, and that's very highly dependent on the type of the plant and what type of compounds it's actually making. But the plant itself is actually, you know, just a massive chemical producer. It's a nutraceutical factory. 450 compounds, over 100 of them with medical activity. There's a whole host of ones that are non-psychoactive. You know, there's the psychoactive, which is the delta-9 THC. You can use these non-intoxicating ones. They're being shown to have more and more therapeutic value all the time. You've got these terpene compounds. And then the other interesting thing is that what you treat the plant, whether you heat it up, makes a difference as well too, because it turns out the plant creates what's called an acid form. And when you heat up the plant to a certain temperature, it takes the acid molecule off of it, and that actually activates it. But we find that for many patients, if they use a juice or a raw plant extract without being heated, they don't get any of the negative side effects that are coming on with that either. So that leads us to What time? Oh, there we go, 5 minutes. So what that leads us to is that cannabis is complicated, okay? It's like any other plant. There's lots of different varieties. You know, I thought tomatoes was an apple. You know, you get the heritage tomatoes, you know, and they're all, what are they doing? They're making different compounds. They have different colors, and they taste differently because they're creating different compounds. You know, cannabis, or, oops, here we go. The growing conditions and the processing also affects the content as well. So chili peppers. I mean, depending on the type of chili pepper and the variety, anybody who's a chili pepper fan will know all about the Scoville heat units and how spicy it is. But it's the same thing with cannabis. I mean, you can get these different strains. It can produce different amounts based on the genetics, you know, of the plants and based on how it's grown. And what that ends up leading us into are all these, you know, different varieties of cannabis. I mean, really, I didn't know anything about this plant until my patients came to me, but it is fascinating. And the names itself are fascinating, you know. You know, you got haze, and you've got the indica, and you've got the cushes, and northern lights, and, you know, purple nurple, and all the rest of the stuff, you know. And they're usually related to some of the fragrances that they're actually making on it. But what you're identifying here are what we're calling chemovars, or different strains. And this is something that's been coming up here as well too, which, you know, different plants produce different amounts. And this was some research that came out of UBC that showed, you know, high cannabidiol strains, mixed versions of it, and the high THC. And you can see most of the stuff that's growing recreationally is the high THC stuff. But these other ones are coming online, and we're learning more about them. And that's one thing that if you're looking into it, you should be aware that you probably want to start off with high CBD type compounds. But the plant itself, like I said, super interesting. This is the same plant. These are the terpenes. So this is lemon peel oil. This is a black pepper oil. This is a lavender oil. This is something from hops. And you can see the plant makes all of these compounds, okay? But what difference is between THC and CBD. So CBD is the black in there. And depending on some of the genetics, how it's been raised, you get different ratios between them. And so that's the new frontier in all the medical cannabis, is identifying these strains that limited those side effects. And it has a big impact, because when you actually just take one of the synthetics and just use a straight THC, you get more of these toxic effects, the psychoses type effects, whereas if you use a more balanced formula, it doesn't. So I'm going to jump through a couple things here just to give you some heads up on this. So let's talk a little bit about the licensed producers versus the dispensaries. So just so you know, any storefront is technically illegal. Illegal. Okay? So the only source for medical cannabis that's legal until October 17th, right? And you and Kamloops have the one store front. I don't want to be driving downtown Kamloops anywhere near that place next week. That is the only legal storefront outlet. Anything else that's out there right now is illegal. They're getting it from the black market. They're getting it through some loopholes that existed. Now, some of those growers are very passionate about the medical side of it. Some of them are in it more for the cash. But we have no idea what you're getting. We don't know the types of pesticides that are on it. We don't know the growing conditions. We don't know if they have molds. We don't know if they have rats running around inside of there, you know. And trust me, I mean, I've been in some of these grows, and they, you know, I mean, I had a friend who went down to Colorado and was like horrified by what they saw down there in terms of, you know, just the conditions, you know. So when you go through that, you need to recognize that the licensed producers have gone through a process with Health Canada that they have to maintain the security, they have to maintain the consistency, there has to be pesticides are strictly regulated, all the rest of that. So that's something to look at. The problem that most patients run into, though, and this is a problem with the legislation, is that you can only access it through a medical doctor or a nurse practitioner. The Medical Association does not want to have anything to do with this. So access starts to become problematic, and the potencies that are out there are really not the ones that most patients are using. And so most patients are probably going to trickle back into a black market, is my prediction, until Health Canada gets around to actually making sure that these things are there. But that's the difference between them. So at the end of the day, with my 1 minute that I have left, Pay attention to the source. If you are looking for it, you've got a great clinic up here. I think Dr. Mitchell does it. Michael as well too. I've met them as well and talked with them at length. You do. I mean, and the unfortunate part of it is that, it's like any number of different healthcare services that we have to pay for now, right? And hopefully that starts to change as the evidence base grows. But MSP has a process that they go through for using it, and more than likely, I don't see anything changing in the near future. So, but long and short of it is that, those types of resources are going to be, you're still going to have to pay for them, is really what it comes down to. Many of the medical doctors, there's many medical doctors that I know of are learning about this. They're more focused on the THC-CBD ratios, which is a very great place to start, but some of the nuances kind of get lost a little bit. We're hoping that naturopathic physicians will be able to authorize that, and we're in conversations with Health Canada. But long and short of it is if you use an oral form, it takes longer to kick in and lasts longer, 6 to 8 hours. It takes about an hour to kick in. If you take a vaporization, it kicks in 5 to 10 minutes, and it's usually gone in 2 to 4 hours. And so those are the ways that most people are using this. So what we usually suggest is that patients look at using an oral form to get the long-acting effects, and then use small doses of the other ones if they need some other sort of a top-up on the other side. But that's yeah, I mean, we could go on lots of different things. I mean, I forget what else I've all got on here. I think I'll probably just end on this one. The integrative part of it. Like I said, there's all sorts of things. Your exercise, your sleep, the types of fats that you're eating in your diet, how much you're, respiration, all the rest of these things, all those important wellness things, those all support all this function as well too. And there's all sorts of interesting stuff coming out of there as well. So we'll be able to take questions after this is all done, but I was 2 minutes over. That's okay.
That's why we gave a 5-minute warning, because everybody's always over. Thank you so much, Dr. Spooner. So let's bring all of our speakers up here, and we'll do questions and answers from up here. We have about 20 minutes or so for questions and answers. We will start with the ones online, but before I do the questions and answers, we're only going to do them if you all, everybody online as well, promise to complete your evaluation forms that were sitting on all of your chairs. And I also wanted to mention just a couple other things. Some people had asked if the presentation will be posted online. And yes, the whole presentation today will be posted online to our YouTube channel. So if you just search for the Arthritis Society on YouTube, you will be able to find that. And I wanted to encourage you to visit arthritis.ca. We have a number of different tools on our website and online resources, including our symptom checker. So it's a great tool if you go on there and just answer a few simple questions. You can email the results directly to you and print it off. And it's a great tool to talk to your or take to your doctor or healthcare professional to show them exactly where you're experiencing joint pains and arthritis symptoms. All right, so I will get started. We did have a couple questions online, so I'm going to get started with those 2 questions, and then we will take questions from the audience. So the first one was actually one that was handed to me in person. I'm on a medication for 4 years for nerve damage on my entire left side, but I'm concerned that I shouldn't continue. As it doesn't seem to have any help or relax my body. It makes me dizzy quickly, but doesn't last before I'm ready to sleep. Could somebody take that one?
Oh, okay. So I'll just address the question about pregabalin or Lyrica, gabapentin. These are medications that were designed initially for patients with diabetes who have a lot of neuropathies for the nerves, and they numb the nerves a little bit. And that's but now they have been extended, to other forms of chronic pain management for different conditions. My recommendation when I would see something like that is I ask that to my patients sometimes. I say, okay, how long have you been on this? And they say 3-4 years. And I say, is it working? And they say, well, I don't know. I take it every day. So I say, well, you know what? There's nothing wrong. This is a symptomatic treatment. There's nothing wrong with you stopping it. You're not going to go in withdrawal. You're not going to get headaches or sweating or whatever. You stop it for a while. And then you go back on it, and then you can assess yourself. If it's working, great, then for sure continue with something that's working for you. If it's not working for you, it's not going to work any better in another 10 years. Don't keep taking it. So I think that you've got to be very smart about what it is that you're taking. I face this all the time with patients with anti-inflammatory medications. Same thing. They take their anti-inflammatories every single day. And I say, well, what happens when you don't take it? Well, I don't know. And then they stop taking it, and they go, well, that didn't change anything. Well, then why expose yourself to a risk, the kidney damage, the hypertension, the stomach issues associated with it? So if you feel that there's a benefit, then it's worth taking the risk. If there's no benefit, don't continue with it. That would be my recommendation. Oh, the second question, what is gelling? It's a new term for me. So I think I mentioned that in my presentation. So we talk about gelling after immobilization. So that's that stiffness that you feel. You sit down for 15, 20 minutes, maybe more when you're waiting to see your doctor, and then you come to get up, and your joints feel all stiff, and then you start walking, and then you're kind of, okay, I'm good to go. That's the definition of what gelling would be. And we do see that there's a lot of gelling in inflammatory diseases, and patients will tell us that, once I'm good to go, I'm good to go, but the minute I stop, I try to get up. A little bit the difference with that, with osteoarthritis, the gelling would be rather short-lived, maybe minutes. Whereas in inflammatory disease, the gelling can be prolonged. Half an hour, 2 hours sometimes. So that's a little bit the difference of the symptoms and how they will be used for us to make a clinical assessment.
Audience? Yeah, audience question?
I would like to ask Dr. Spooner, you mentioned locally Dr. Mitchell and somebody else who had it. And what about topical use? How are we going to know if we go to the one legal store that's going to be, is that going to be the only source? Can we be assured of that?
Yeah, well, you're not going to be able to get topicals. You're only going to be able to get dried flower at this new store, at the one store. So, no, the oil, you could. There's some discussion that maybe a CBD oil may be allowed right now, and that's still there. But right now, it's just dried flower. Is all you can get. Yeah, no, I mean, yeah, and if you're smoking, and again, I would suggest if you do vaporize. I mean, some groups are trying to get in these different strains that are higher CBD content, but again, you're going to need to know what some of those are. So, for example, some of the licensed producers, they produce a high CBD strain medically, but that may not necessarily translate into there. What you can do is ask the store if they can bring in a product like that, because what can happen is those retailers can then go back to the Cannabis Control Board, and they can find a supplier and then bring that in if the patients request it. And technically, it's not supposed to be medical going through the recreational world, so this is this confusing little space that we kind of live in right now.
So what do you ask for if you want them to bring in an oil that you could use?
Let's chat about that afterwards and see what that looks like. But again, there's like, for example, if you were to use one of the oils there's a company for Med Relief, for example, which is one of the big producers, and they've made a topical, and they bring an oil called Avidecal. That's a high CBD oil. And if you go to, see Dr. Mitchell or something like that, they can get that, and then it gets shipped to you in the tincture, and then you have to mix it together in the cream and then put it in there.
You go through Dr. Mitchell, but he'll send you to another place like Whistler. That's where I went.
Exactly.
They have every type you want.
Yep.
You call there, and the person answers, well, do they have the education? And, and then you buy a bottle, it's $100, and nothing happens, and then you have to rebuy. So who's the person that can guide you when you call those Whistler companies or companies like the speaker?
Yeah, right now, nobody.
Yeah, they're like somebody that's off the street. And
Yeah, the bud tender is what it is. And this is the problem. This is the problem with the system, right? Is that, and again, it's a hopefully, they keep on saying it's a process. So, yeah.
I'm totally new to this. You had oral and vaping written down. How are you taking it orally, and what is vaping?
So, Yeah, so the question is what's the difference between what is vaping and how would you take it orally? So the LPs all make a product that'll be in an oil. It'll usually be like a coconut oil base or an olive oil base, and it'll come in a dropper, and then you'll start with a low dose, say a few drops, and kind of step up with that. And that's how you would get that product.
Yes, Dr. Spooner, are you aware of any studies on cannabinoids and restless leg syndrome?
Let me get to that one. I'm going to answer vaping real quick. So all vaping is you use a small little, it looks like a little, they look all sorts of different things, a little pipe or something like that. It's some of them are like, they've got a little heating unit in it that just warms it up so it evaporates off the active components of it, so it doesn't burn it. I don't know of any of the restless legs right now. I haven't seen anything on restless legs yet. The studies that we've seen, have been more to do with sort of chemotherapy-induced nausea. There's some elements around pain with that and muscle spasticity in MS patients. Those are the ones that we see the best evidence for.
Okay, here you go. Yep. No. I think we are still in the very infancy of learning what fibromyalgia is all about. I think until we can define it better, I don't think that there's going to be biologic therapies for that for now. Yep. Yep.
And you try your prednisones, you try your methotrexates, then you can go on to the cannabis.
Good. To the biologics. Yes, and to clarify, this is because we live in BC. If I was in Quebec and I want my patient to start on a biologic right off the bat, I'm allowed to write that prescription and the Quebec government will cover for it automatically. And this is what our national program, the pharmacare program that they want to develop is going to maybe bring a little bit more equality and equity to our patients. I've had some patients move from BC to Alberta to access the biologics better. So the process by which that application process I showed you has to do with our BC pharmacare criteria. Every province is different.
Dr. Spooner, you mentioned that the only legal place to get stuff was the one here in Kamloops, and that they had flour?
Yes.
Now, is that flour for baking?
No. It's basically what they've done is they've taken, so when you take a look at the cannabis plant, it creates a flower on the top of it, okay, what they call the bud, okay, and that's what's available.
And
so,
how do you use that?
So basically what's done with that is you take a small amount of it and you crumble it up into usually one of these vaporizers, and then you would warm that up and inhale it through one of these things.
Okay, thank you.
Yeah, and now the other thing you could also take a look at is some people take those and mix it with something like some olive oil or something and actually make a bit of an oil from it, and those things, those recipes are out there. Yeah.
Another online question for Dr. Spooner. Could you just repeat who you would contact to become a licensed medical user via the federal government and have oil delivered to my home?
So you need to get that paperwork done through a medical doctor. They would fill out the documentation and then send that to any one of the licensed producers. There's a website. You can type in licensed producer, Health Canada, and they'll bring up a list of all of them by province. And then you have to sort through and figure out which one it is that you want to use.
Hi, this is for Dr. Hudson. Just a question moving forward with rheumatology. Do you see more medical students going into that field? I know in Kamloops there are only 3 rheumatologists, and I personally had to wait a year to see you. Do you know if there's a push by the government to educate more?
Actually, I would like to say that there's been at the level of residency, so the way it goes is everybody goes to med school, then after med school you have to decide the specialty. And so yes, there have been quite a few more rheumatology residents that have graduated in the last few years. Unfortunately, they seem to be staying in the urban centers, such as Vancouver, or it's at large centers. So it's not easy to access care. And many people, I follow patients from Cranbrook and Terrace and Kelowna, where they have some, and so the access to care is a huge problem that I think the Arthritis Society is trying to address. I'd like to say that in my practice, maybe one of the things that's facilitated over the last couple of years, I now do video conferencing. And so especially for my out-of-town patients, I still need to physically see them at least once a year, put my hands on them, see them. But certainly that has facilitated access for different patients who are from out of town, winter months when they can't travel. But I agree with you, this is a big problem. And yeah, I think it's trying to be addressed, but I don't know of a impending solution or anything like that. Yeah.
Wanted to add to that too. As an organization, the Arthritis Society certainly recognizes that the need to get rheumatologists into the right locations. We do have quite a few graduating, and we recognize that, but not all of them are in the places where we need them. So we have started funding a fellows rotation. So we had our first fellows rotation where we sent a fellow like a newly graduating rheumatologist to Kelowna to shadow the Kelowna rheumatologist, and we hope to do that in other remote locations, really to help them to see what amazing communities are out there and what a great need there are in these communities to try and entice them to get into the rural cities. We are funding a rheumatologist also up in Prince George. He's the only rheumatologist in northern BC, a permanent rheumatologist in northern BC. So we are helping to fund him to hire a nurse to increase the efficiency of his practice. So we are doing as much as we can to address that need, and we would love to have conversation to see what we can do in Kamloops too.
A question for Dr. Hudson. Or sorry, Dr. Spooner. Yep. Sorry, I'm sorry. You're cute, but he's a... This here, vaporizing the bud, what is this, inhaling this, has it any compromise for lungs? Like people have already got compromised lungs. What more damage could it possibly do? So definitely for someone with any sort of obstructed chronic COPD, asthma, those types of things, definitely, I mean, I definitely wouldn't like to be seeing patients use vaporizing that way. That's where the oils come in, and using an oral dosing can sometimes be a much better option. And it's interesting because that's how we actually got oils allowed under the law, is there was a patient that had a concentrate, she had lung cancer. When they said, you're allowed to have it as a smokable form, and she said, well, I have lung cancer, why would I smoke this? And that basically opened it up because of a charter challenge that happened that way. You can get it through a medical professional, through your medical doctor. Yeah, but you'd have to get them to prescribe that. Or authorize it, I guess, is what it is now. Yeah.
I had a question. Has there been an increase in the amount of arthritis? Like, say, from 40 years ago till now?
No. I think that the incidence of arthritis is very similar than what it used to be. I think we are better at recognizing it earlier on. So perhaps that's why it appears to be more prevalent in the population. But no, not an increase. What I'd like to say is we have had a huge impact at improving the prognosis. It used to be that we used to tell our patient who had inflammatory arthritis that their life expectancy was reduced by about 7 years. We used to talk about it reduced the number of years of lifetime because it doesn't just affect the joints, it affects cardiovascular disease, so heart disease, strokes, and with time, as we're better now at treating the diseases and treating the comorbidities around it, we know that we've had a tremendous impact at improving not just functional outcome. I like to tell my patients, and I'm sure some of you have lots of damage, but I like to tell my new onset patients, we don't see that anymore. We don't get there anymore. We've had a huge impact at improving function, but also improving life expectancy. So much better at that. Yep.
I had one other question there, just regarding osteoarthritis. Not only do we need rheumatologists, we also probably need better access to the surgeons, which seems to be, I mean, living with arthritis when you need surgery seems to be a problem in the province as well. Yep. I mean, you can do all the things to maintain and do that sort of thing. So not just rheumatologists, but also
And the advice I give my patients when we're talking about, surgery is not overnight. You're thinking about it. I tell my patients, don't wait until you're really, really bad to consider it. Because if you wait until then and then we make the referral to the surgeon, you're still 6 to 9 months from seeing the surgeon. And then once they see you, you're still 6 to 9 months to be on the OR slate. So when we initiate a surgical consultation, it doesn't mean you're getting the surgery right away. It just gets the ball rolling. So get that ball rolling earlier, then they see you, then you're on their radar. If you're not that bad, that's okay, but at least you're on the radar so that if you do deteriorate. So don't hesitate to say, like when I'm telling a patient, maybe we should send you to a surgeon, and patients say, I don't want an operation. I'm not sending you for an operation. I'm sending you for an informed, session with a doctor who can tell you what he can or cannot do with your condition, and then we get that ball rolling. So I think preemptively planning ahead, yes, I agree with you, there is a big problem from the surgical access, although I think the government has put more money into hips and knees, and they are being done faster now. But I think that as myself as a rheumatologist, I think as family doctors, or I think as patients, advocate for yourself. Say, I think I need to see the surgeon sooner than later.
Dr. Spooner, I'm a bit confused. CBD oil would be probably, for most people, a better alternative because of not wanting the THC. But what you're saying is you get the referral for the CBD oil from your physician. But even when you have that, you have to go to a store that isn't licensed.
No, you have to go to the licensed producer.
So they will have it in that store?
No, it'll be mailed to you.
Okay,
Yeah,
so it is available, but it is a long process.
It is,
You can get it from one of the shops, but you don't know what you're getting.
No, you can't get it from one of the shops.
Well, my daughter walked in and got some from one of the shops here.
An illegal shop.
Okay, so you can get it, but then you don't know what you're getting.
Exactly.
Okay.
Yeah.
Okay.
So the way it works right now is that you've got these, I believe there's 94 licensed producers right now. And your medical doctor who signs off has to fill out paperwork, which then gets sent to the licensed producer. And the challenge is you have to figure out which one you want to use, right? Because right now what happens is it's very difficult to move your paperwork from one producer to the next. So you may say, well, let's try Whistler Medical, for example. And if that one doesn't work, then you have to go get more paperwork to go back to another one, say Aurora, okay? So that becomes part of the challenge, is navigating this paperwork minefield to go through it. When the licensed producer gets it, they then contact you or set up some way to communicate with you, and they mail you a supply, and then you're set up with the amount that the doctor has authorized for you. So you may get 3 months worth, you get a certain gram amount that you're allowed to take. And if you use a little bit more than that, then you have to wait until a certain period of time has passed before you can get more of it. I've had patients that have run through that. So, yeah.
Every supplier has a different product? Is that what it is?
Yes.
And they're not regulated? They're not all the same?
No, the suppliers will be standardized for CBD and THC. They'll tell you how much you have. Like you'll get one that has 20 milligrams of CBD and 2 milligrams of THC. Or they may have a product that's 10 milligrams of each or 20 milligrams of THC. And so they've got that type of thing set out in terms of standardized dosages, okay? But the other part of it that gets more complicated is that not all the plants are the same and they do different things. And so this is based on a number of different factors, how they're extracted, how the plant is actually produced. So for example, if you make an oil, so many of the suppliers will take the bud and they'll use that in their recreational market, and then they'll take the leftovers and they'll extract the oil out of that, and that becomes the oil. That's a very different oil in its effect than one that comes straight from the flower. There's a lot of different other compounds that are in the flower. And so that's where the challenge becomes in sort of the prescribing and finding out what works for you. And on top of it, they're usually these crazy names, you know, like they're Alien Dog or Rockstar Kush or something like that, which makes no sense about what it is that you're actually looking at. So what's really needed is we need, you know, people that are educated about the product to be able to help you through that. And again, where that's happening, we don't know where that is right now. I mean, there isn't room for that in what we have.
So even if your doctor prescribes you something, it's up to you to decide
which one. Some of them will, some of them won't. There's more of them, but there's not many that do. And see, and yeah, so and that becomes part of the challenge is that how do you, like I said, navigate this Byzantine network of things. So.
Okay, we're going to take 2 more questions. I have one online, and then we'll go over here, and then hopefully you guys can stick around maybe for other ones. So I gave Dr. Hudson the question already for the online one. It was about psoriatic.
So the question was, can I talk about psoriatic uveitis? So as I mentioned, psoriasis is a condition of the skin, which many of you may just recognize easily. About 1/3 of patients with the skin disease can get an arthritis. Interestingly, it's a constellation of different symptoms too. And so sometimes, as I mentioned, it can affect the eye. And names for that would be iritis or uveitis, when that inflammation now is affecting the eye. The symptoms for that are usually red, painful eye. Painful. Patients will know, oh my goodness, they can't look at the light because of the photophobia. There's a lot of pain. This is a medical emergency. You need to go see your doctor. You need to have a quick referral to an ophthalmologist because it can affect vision very quickly. It is usually treated initially with some topical drops, but sometimes, if very aggressive, needs to be taken. Patients need to take steroids orally. And now we're actually using biologics to manage uveitis. So there was a recent New England Journal of Medicine study that was published, and they're using biologics for the management of uveitis. My biggest recommendation to my patients who do have, because uveitis can be recurrent, it's to keep these drops in their fridge. And so if they start having the symptoms, you start using your drops ASAP, and then you go see your doctor to really try to catch it or nip it in the, as soon as possible to prevent the consequences of uveitis.
Okay, this is a question for Dr. Hudson. I take Xeljanz, and it makes me very dizzy.
Okay.
And I was wondering if the Xeljanz XR would be different.
Mm-hmm. So Xeljanz is it's a biologic. It's a synthetic biologic, so it's not like the monoclonal antibodies that I pointed out. It is an oral biologic, which is what's been really interesting for patients because most of the biologics that we have so far are by injection, either subcutaneous or by infusions, such as intravenous. So Xeljanz has now been around for quite a while. It works well. Yes, there are some side effects associated with it. Mainly, a lot of patients get GI symptoms, dizziness. So there's a new formulation because it's taken as a twice-a-day medication, so morning and supper time. But now there's an extended release. So that's what Xeljanz XR is. It's an extended release product. I have to admit, I have no experience with the XR because it's just come out. So I cannot tell you whether or not I think side effects will be better or not. I think there's no harm in trying. As I said before, we're all chemically a little bit different. What works for one doesn't necessarily work for the other. And I think that the best thing is for you to try it and see. If it works, great, great. If it doesn't, then it's to move on to something different. But myself right now, I have no clinical experience with the extended release because it's just come to market.
All right, thank you everybody again for coming. We really appreciate you taking the time, and thank you so much to our speakers as well. Again, please remember to fill out your evaluation forms before you leave, and thanks to you who joined us online as well. You can just put them by the table as you exit.